Thank you everyone so much for joining us today for our sixth session in this Implementation Science Reading Course series. Today we have a wonderful presentation lined up for you by two of our fabulous implementation science researchers here, Dr. Meredith Boyd and Dr. Callie Walsh-Bailey, both from the Department of Medical Social Sciences, and they will be talking to us about outcomes of implementation. So whenever you're ready, Dr. Walsh-Bailey, go ahead.
Thanks, Sarah, and thanks everyone for joining today. And a little bit of implementation science fun history. Meredith and I worked together on my first implementation science paper when we were both pre-docs, so it's really fun to get to present with her today. So we will start off by defining implementation outcomes. So what are they? What kinds of outcomes do we think about in implementation science, and where do these fall on our subway line? We'll introduce, since we love frameworks, two frameworks that are commonly used to help us evaluate implementation outcomes. And then Meredith will talk about why it is important to think about implementation outcomes early rather than waiting towards the end. And then we will finish with our case example, then go into our group discussions. And an important guiding theme that you'll see throughout our presentation is that we don't conceptualize equity as a standalone outcome, but rather it's really a guiding concept that can be operationalized throughout the implementation process and in the various outcomes that we assess. So implementation outcomes are getting us to the end of our subway line. We can think about implementation outcomes both in our hybrid effectiveness implementation trials, where we're assessing both the effectiveness of the thing that we are implementing, as well as how well or how much we implemented it. And we also observe implementation outcomes and measure these in studies that are testing implementation strategies. So outcomes that tell us the effects of our implementation strategies. So implementation outcomes, and there's a little bit of overlap with some service outcomes, which we'll touch upon, really tell us how much or how well people do the thing. So in clinical and public health research, we think about whether the thing or the EBP is effective in changing patient or population health outcomes. In implementation science, we think about really the effects of all of the strategies that we use to help people and places do the thing. So a more formal definition from Proctor and colleagues is that implementation outcomes are the effects of deliberate and purposive actions, which are our implementation strategies, to implement new treatments, practices, and services. And they really help us evaluate implementation success. So for example, the thing got to 80% of eligible patients. That would be an implementation outcome of REACH. Implementation outcomes can also be proximal indications of the process or the act of actually implementing our EBP, and maybe a precursor to getting to clinical effects. So for example, if we think about a couple of process chains, if it's feasible for people to do the thing, so if it's feasible for providers to deliver the EBP, they might be more likely to adopt it or pick it up and decide to use it in their practice. If they implement it well, meaning they deliver it with fidelity or deliver the thing as it's intended to be delivered, that might help us get to a sustained effect of the thing. We can also think about going from efficacy of the thing, so kind of one of our more traditional clinical research focus areas, to implementation fidelity. Again, did we deliver the thing as it's intended to be delivered? Did we follow our protocols or our treatment guidelines? And if we do that, we think that that will help improve effectiveness. We can also think about kind of this process chain for getting to improved quality of care. So if we implement well, we do all the things we're supposed to do, that might make care more efficient, which might then lead to greater patient satisfaction, and we could see changes in quality of care. So to orient where this is in our implementation research logic model, you heard last session about implementation strategies and how those work, and our outcomes are really the effects of those implementation strategies. And sometimes we also think about those then leading to service outcomes. And that's in contrast. Ooh, hopefully it'll let me go forward. There we go. Down at the bottom of our implementation research logic model, again, we have our innovation or the EVP or the thing and how we think that works to change outcomes. And then we often measure those outcomes at patient-client outcomes. So really the takeaway here is that our implementation outcomes are operating at a different level than we would typically think about in clinical effectiveness research. So a couple of commonly used implementation science frameworks, and you may have already come across these in your own work or in your readings, are REAIM, which is the Reach, Effectiveness, Adoption, Implementation, and Maintenance framework that originally comes from public health, and we've adopted it in implementation science. And then our kind of own fields implementation outcomes framework that was developed by Proctor and colleagues in 2011. And so we kind of see this chain of our implementation outcomes. So we think about things like acceptability. So is the thing likable? We think about adoption. So are the people and places that are supposed to deliver the thing actually picking that up and beginning to use it in practice? Is the thing appropriate? So is the EVP a good fit for the population or the health topic it seeks to address? How much does it cost to implement the thing or that EVP? So rather than traditional cost effectiveness or cost benefit analysis, we're really thinking about costs of implementation. So things like how much does it cost to train providers to deliver the thing? How much does it cost to get all the materials and the equipments to deliver that evidence-based intervention, et cetera? Feasibility, how doable or how easy is it to do the thing? Fidelity, are you doing the thing, again, the way it's intended to by a treatment protocol, guidelines, et cetera? Reach, how many people that are eligible for the thing are actually getting it? Or we could think about longitudinal, like health promotion programs. Are people staying engaged in the thing over time? And then sustainment. So thinking about, is the thing maintained over time in its delivery setting? So for example, is a clinic continuing to deliver the EVP over time? Or what is telling us that they might be able to do that? We think that all of these things will eventually get us to improved service outcomes. So improved safety, improved effectiveness, improved timeliness of care, all of these things that we care about in service of ultimately improving patient and population health. So we think about implementation outcomes at a few different levels and at a few different time points in the process of an implementation study. So while we sometimes get implementation outcomes from consumers or from recipients of the evidence-based intervention, you can see that we're often actually getting these data either from the deliverers who are supposed to be implementing the thing, or the sites, so the organizations or the settings in which the thing is supposed to be delivered. And we might also get some data from administrators or leaders of those sites that are delivering the thing. You might often see, especially in kind of pilot feasibility studies, acceptability, appropriateness, and feasibility are very commonly measured implementation outcomes. And we really think about these often as precursors to adoption or kind of happening at the same time as adoption. You can imagine that if people like the thing that they're supposed to deliver, if they think it's appropriate for the population they're serving, if they think it's easy or doable, that they're going to be more likely to adopt it or pick it up and start using it in routine practice. And we might start seeing more of these things like fidelity, again, delivering the thing as intended, happening a little bit later, with things like sustainability happening late. And even though we might see these outcomes happening at different time points, again, Meredith will touch upon some ideas about why it's important to conceptualize your implementation outcomes early. And we really want to highlight here that even though sustainability is a later outcome, this is one that's especially important to think about early. So there's this whole kind of concept of designing for dissemination and sustainability, which has you think about sustainability and sustainment from the onset. This paper from Proctor and colleagues is one of several that came out in the last few years. really highlighting the importance of thinking about equity in implementation science, and in particular, thinking about equity within our outcomes. So they recognize that it's important to focus on reach from the very beginning, so ensuring that our most vulnerable populations are engaged from the very start, that we want to broaden communities and settings in which implementation occurs. And this article acknowledges that reach is not the only outcome in which we should think about equity. And so they also recommend to us to use equity as a lens or as a focus for understanding our implementation outcomes. And in the next few slides, we'll highlight some examples of how to operationalize equity within each of the re-aim outcomes. So we went over Proctor in a little bit of detail, so we're going to touch upon reach. And you'll see some similarities. There's definitely some overlap between re-aim and the Proctor implementation outcomes framework, but some different terminology used. So Glasgow and colleagues have an article with some great examples of how to think about and measure different outcomes in the re-aim framework. So first, starting with reach, again, this is who is supposed to benefit from the thing or from the EVP, and did that actually reach them? One way that we can think about equity when measuring reach is asking questions like, does reach differ by community, by organization, by provider, or by client characteristics? And there's lots of different ways that we can operationalize that in our measurements. So for example, we might do that quantitatively. So you might imagine using EHR data to look at differences in who is receiving an intervention by different demographic characteristics, race, ethnicity, gender, sexual orientation, insurance status, et cetera. You could also do that qualitatively by, for example, doing surveys or interviews with participants who maybe were contacted, who were eligible for an intervention, but ultimately did not participate, or maybe started participating in something that's intended to be longitudinal, but didn't continue, and trying to understand why that happened. And thinking about effectiveness, again, we can, especially in hybrid studies, think about effectiveness as clinical effectiveness, but in implementation research, we most commonly think about the effects of our implementation strategies. And so this outcome is asking about what is the most important benefit that we're trying to achieve in terms of clinical effectiveness, and what are we trying to achieve with our implementation strategies. One way to think about equity with effectiveness is asking if some constituents experience greater benefit from the thing, from the EVP, or from the implementation strategy than others, and if some constituents are actually experiencing negative effects. Again, we can assess this qualitatively, quantitatively, or using both approaches and a mix of methods evaluation. So for example, again, quantitatively looking at differences in implementation outcomes by provider demographics. We could also do this qualitatively in surveys or interviews to get patient narratives about their experiences, to see if there were any unexpected positive ripple effects or any negative unintended consequences. Adoption is having us think about where the thing, whether program, policy, or treatment is applied, and who applied it. So who is the provider or the deliverer? One way to think about equity in adoption is asking if adoption is equitable across communities, organizations, clinicians or providers, and clients who could benefit. We might do that quantitatively, for example, by looking at geographical differences, for example, rural-urban differences between adoption, or again, qualitatively, surveys or interviews with providers to understand why they did or did not adopt, and whether there are any systemic differences. So for example, if it's rural-urban and we're looking at the digital intervention, are there barriers to digital access in rural communities? Are there policies that make it harder for certain communities or settings within those communities to deliver? When we're thinking about implementation from re-aim, again, this can map on to several of our implementation outcomes from the Proctor framework, fidelity, for example, being one. So REAIM implementation outcome has us think about how consistently the thing is delivered, how it will be or was adopted, how much did it cost to implement, and why will or did the results come about. So one way to think about equity in implementation outcomes for REAIM, if you're measuring, again, fidelity, is thinking about, does this differ by any characteristics at one of these levels? Or for cost, thinking about, does the cost represent a greater financial burden for some sites compared to others? You might do this quantitatively by looking at site characteristics or demographics of the providers. You might also do this qualitatively, for example, doing interviews to understand how providers or how sites adopted an intervention and whether that was driven for needs to address social determinants of health or structural factors. And finally, in REAIM, maintenance is analogous to sustainment or sustainability in the Proctor implementations outcomes framework. And we think about when the program became operational, how long it's been sustained, and how are the results sustained. And we think about this at a couple levels. So kind of site level sustainment, so keep the program going at your site. And if we see the effects continue, and that could be at the provider or at the patient or client level. One way we can think about equity is asking if maintenance is equitable, again, across these multiple levels, who could stand to benefit. We might use quantitative data like getting a community profile from a community needs assessment or things like census data to understand characteristics of a community and whether sustainment is associated with higher or lower deprivation in a community, for example. And again, we could do that qualitatively through interviews or focus groups to really gather narrative accounts of the impact of the implementation strategies or the intervention and different factors that allow for sustainment. So I'm going to hand it over to Meredith here, and she's going to finish up with talking about thinking about implementation outcomes early and then walking through our case example.
Great. Can you hear me okay? Awesome. Thank you. Yeah, so I'm excited to talk about reasons to think about outcomes early. So this is like a nice little quote, knowing where you are, where you're going is the first step to getting there. So if we think back to like our beautiful subway line that we've seen across a few presentations, maybe you just love riding trains, but if you're in Chicago, you're probably getting on the train and you have a specific place you want to go in mind. And I think similarly, we want to be sure that when we're setting out on an implementation project, we have a good sense of what our end goal is. Okay, so why would we think about implementation outcomes early? So first, it helps you recognize the potential for impact or gaps. So if we think about an evidence-based innovation and like as water and like how many people could drink from this like huge lake of water, how many people could benefit from it? But then we ask ourselves, can programs adopt the intervention? And we assume this optimistic idea that 50% of programs will adopt this beautiful evidence-based innovation. And then we say, well, can providers deliver it with fidelity? And we assume that 50% fidelity. And then we say, well, will the program reach its intended population? And we assume 50% of the population intended actually receives the intervention. And then we ask ourselves, well, will this be sustained over time? You can see that we've gone from this vast lake of potential of helping people to just a single cup of water. So if we think about this 50% threshold at each of these stages, it ultimately gets to 6% population benefit. And as a side note, some states would be really happy to see a 50% adoption rate. So this really helps us think at each step, where are places that we are losing water and where can we intervene and ultimately improve the population benefit of the intervention. And then the other thing I'll say is that at each of these steps, really as Callie was talking about in other parts of the presentation, those are opportunities for promoting equity. Asking ourselves again, like, are there certain communities that are more or less likely to adopt the intervention? What can we do to bring those communities along that are having more difficulties? Are there populations that are harder to reach that we can specifically tailor our strategies to make sure that they're receiving benefit? All right, so the next reason to think about outcomes early is it helps you think at multiple levels, including the system level. So again, when we think about efficacy and effectiveness, really our delivery system is either tightly controlled in a way that things might not be in the real world, or it remains this unmeasured but probably important variable. And we're really just focusing down at this level of the patient or client. And in implementation research, when we pull forward these outcomes that have more to do with system, organization, and provider level, that really brings to the forefront our system and all of these variables that likely matter that remain unmeasured in efficacy trials. We're really shining a light on them. And then again, when we think about equity, often these isms, racism, sexism, things like that are perpetuated at these system levels. And so when we're able to bring the whole system into view, that gives us different ways of identifying when inequities are occurring and actually doing something differently rather than continuing to try to intervene at just this like individual level. Another reason to think about outcomes early is it helps you not get stuck in pre-implementation or formative research. So a central focus of implementation research is testing and evaluating our implementation strategies. And in order to do that, our main outcomes of knowing if an implementation strategy is effective is looking at these implementation outcomes. And so if we're centering our implementation outcomes, that forces us to move a little bit further down the pipeline rather than getting stuck in just characterizing barriers and facilitators, which is very important, but ultimately not the end goal. And then it's important to think about outcomes early because it helps you select the appropriate study design. So if you, for example, are really interested in understanding staff adoption of an intervention, so the proportion of the staff who you would like to deliver the intervention, how many of them actually adopt and do deliver the intervention. If that is the question you have in your outcome of interest, then a small pilot with 2 therapists who are already excited about the intervention is not going to help you answer that question. And so if that's the group you have available to you, that means you either need to be thinking about a different implementation outcome. Maybe perhaps you could look at fidelity. Can these therapists who have decided to use the intervention use it as intended, and what can we do to help them with that? Or you're going to need to think about a different study design in a different population. So again, thinking to yourself, like, what is the most important question that I have will help you determine what study design is appropriate, or the opposite. Like, if feasibly you only have access to a couple organizations, you probably can't ask these questions about, number of organizations that are choosing to adopt an intervention. And then in addition, so thinking about outcomes early helps you engage your partners in implementation research. And so there's, our terms are maybe a little bit different, but there's nice like overlap between quality improvement, process evaluation, and implementation research. And so if you have different constituents with these different expertise working together, forming that shared language and determining, what is the direction that we're going together can really help then like capitalize on that wisdom across the group. and make sure that everyone who's collaborating has that like shared goal of what they're working toward and a shared understanding. And there was one other thing I wanted to say about this, but I am now forgetting what it is. Oh, yes. The other piece with this is not only is this helpful when you're thinking about your research partners, but it's also even more so important when thinking about your community partners. You know, what are the implementation outcomes that are most important to your partners, and making sure that there's agreement on that, and that those are the things that are being measured to make sure that they're changing over time. Okay, so hopefully at this point, you're really excited about measuring implementation outcomes. So now we're going to return and build on our case example. So this example, again, was a screening and brief intervention for risky drinking. And the gap was that even though this practice was best practices and mandated, rates continued to be low, and then screening was often based on clinical judgment, which was found to be racially biased. And so, as we've seen before, we've got the thing, the screening and brief intervention that was recommended. And then we've got these primary health outcomes, patient follow-up with primary care, and then reduced drinking. And then, as we talked about in previous sessions, this was the careful work done to determine the barriers and facilitators in this context. And these were the implementation strategies that were chosen. And then finally, these were the implementation outcomes. So looking at reach, percent of adolescents who were screened, percent who received the brief intervention, and percent who received referrals. Adoption, so the number of nurses out of total nurses who engaged in the screening. And then implementation was the accuracy in use of the risk algorithm. And then maintenance was looking at reach over time. So not just looking at it at one initial time point. All right, and so we will go ahead and wrap up there. Thank you for your time, and I'm assuming you'll be broken into your groups now.